caliper position. Here it's visible adjacent to the bladder, on the right or left, at the top or bottom of the screen. It depends from the setting of our screen. We usually scan with the caliper in this position, on the right of the screen. Now, how to optimize the image? For a good scan, the image of interest must occupy more than 75% of the screen, using depth and zoom. So, using depth and zoom, we can obtain the correct image, occupying more than 75% of the screen. Now, real zoom. The zoom helps to enlarge an image section on the monitor without the graining effect. For example, we can use the zoom here to assess the endometrium. We can see the endometrium very well, and we can assess its thickness, morphology, and then vascularization. Focus. Adjusting the focal zone to the area or just behind the area of interest will increase resolution and therefore image quality. Focus. This is not correct. The focus should be here. So, zoom, focus, and then frequency. We usually have 3 frequency settings in the machine: resolution, general, and penetration. Resolution means high frequencies, and we can use it to investigate superficial structure. However, we usually use general frequency. We can also use penetration, means low frequencies, to study structures. The general frequency and the focus in the right position. Then we can check the gain. Increasing the gain increases the echogenicity of the organ. And to set the gain, we can assess, for example, the bladder, an anechoic structure. Then we can increase the gain to obtain an hyperechoic image of the bladder. Then we can reduce the gain until the bladder becomes anechoic again, and then we can obtain the correct image with the correct gain. Now we are going to talk about color Doppler examination. First of all, the PRF. Check the PRF. Should be between 0.3 and 0.6 kHz. For example, in this image, this is a myometrial lesion. The PRF is 1.5 and no vessels are visible. However, if I put the PRF 0.6, we can recognize some vessels. This is the right PRF. Then we can adjust the gain, increasing the color gain until the appearance of noise. Then we can reduce the color gain until the disappearance of noise. And then we have the maximum color sensitivity without noise. Now, how to assess the anatomy of the uterus, ovaries, and then parasites. How to assess the uterus? To assess the uterus, move side to admit all the organ in a longitudinal section, and then we can rotate the probe 90 degrees to assess the uterus in a transversal section, moving the probe from the fundus to the cervix. Then we can measure the uterus. This image shows how to measure the uterus, the long axis from the fundus to the cervix, to the external uterine os, and then the anterior-posterior diameter from the anterior to the posterior wall, perpendicular to the endometrium. And this image shows how to measure the third diameter of the uterus in a transversal section. Then we can assess the endometrium. In this case, the endometrium is in a proliferative phase, pattern. To assess the endometrium, we can use the real zoom as I showed you before. After the evaluation of the uterus, we can assess the ovary, moving the lateral. We can assess their mobility, pushing the ovary against the surrounding organs. Now we are going to assess the mobility of the ovaries. For example, this video shows a normal right ovary. The ovary is mobile when pushing it against the surrounding organs, including pelvic wall, uterus, bowel, and caudally uterosacral ligament. Shows a left ovary fixed bowel. I show you again. Left ovary fixed to the bowel. This is another example. We can see the left ovary with the cyst, and the ovary is fixed to the we can see the laparoscopic view showing the left ovary with the cyst inside, and the ovary was fixed to the uterosacral ligament. Then we can measure the ovary. For example, we can measure the ovary as this image in 3 axes in a longitudinal and transversal section. Then we can use color Doppler examination to assess the vascularization of the ovary. What about fallopian tube? The normal tube is difficult to visualize at ultrasound examination. Sometimes it is possible to see the fimbria when some and with transvaginal ultrasound examination, we can assess the structure surrounding the cervix, including vesico-uterine septum, rectovaginal septum, and parametria. In the last few years, with Antonia Testa, we tried to assess the parametria at ultrasound examination, and now I'd like to show you some video clips. Vesico-uterine septum and anterior parametrium. The vesico-uterine space, the vesico-uterine septum, can be evaluated by pushing the vagina and uterus against the bladder. We place the probe in the terminal part of the ureter next to the bladder to assess the hyperechoic tissue surrounding the ureter. This is the empty bladder. This is the ureter, and this tissue corresponds to the anterior parametrium. Then we can repeat the procedure to visualize the contralateral anterior parametrium. In this video, we can see the uterus, empty bladder, and this tissue is hyperechoic tissue, responds to the vesicouterine septum. In this case, the septum is free. When pushing the vagina and the uterus against the bladder. Whereas in this video, the septum is fixed when pushing the uterus against the bladder. This septum is fixed to the uterus and bladder. Now, lateral parameter. To assess the lateral parametrium, we should visualize the ureter in a longitudinal section. This is the ureter in a longitudinal section with the uterine vessels. Then, at this level, we should rotate the probe 90 degrees to obtain this image. Cervix, pelvic wall, ureter in the middle, and the tissue between the cervix and the pelvic wall with the ureter in the middle corresponds to the lateral parametrium. In this video, this is a transversal section. We can identify the cervix here, ureter, uterine vessels, and pelvic wall. And the cervix with ureter middle corresponds to the lateral parametrium. We can assess the medial and the lateral part of the parametrium. This is the corresponding parameters at laparoscopy. We can see the iliac vessel, uterine artery, and ureter. Then lateral parametrium, mid and lateral part. In this video, we can identify the retrocervical region in a longitudinal section. Then we can slowly lateralize the probe to assess the posterior hyperechoic tissue surrounding the cervix, corresponding to the uterosacral ligament. We can then repeat the same movements on the other side. Finally, we can rotate the probe 90 degrees, and by moving the probe craniocaudally, we can assess these structures surrounding the cervix in a transversal plan. Then we can insert the probe until the posterior vaginal fornix in order to assess all the uterosacral ligaments, right and left. Now, the last two videos in the vagina, and we can assess vagina, wall, rectum, and the hyperechoic tissue between rectum and vaginal wall, and we can assess its mobility by pushing the probe against the rectum and the vagina. This is another video showing the hyperechoic tissue between rectum and vaginal wall, and we can assess it by pushing the probe against the rectum and the vaginal wall. It was the last video, and then conclusions. We can optimize an image using real zoom, depth, and focus. Transvaginal sound scan is a dynamic examination permitting assessment of organ mobility. Transvaginal ultrasound examination allows evaluation of the uterus, cervix, and ovary, and also evaluation of the structures surrounding the cervix, including vesicouterine septum, rectovaginal septum, paracervix, and uterosacral.
informative talk, Francesca. As I say, I think the importance of the correct settings for image optimization can't be stressed enough, because that's the fundamental of everything we're doing the scanning. And then measuring the correct. But I must say, I'm not embarrassed to admit that whenever I attended these essential courses last year and this year, I always learn something new. I must say, I don't normally find the ureters when I'm scanning, so I think it's amazing that you're showing just exactly what we can see. And I think it's really important as well that people remember to look at the settings when they sit down at a machine, and not just go with whatever, because somebody could have been scanning a different organ. So, really excellent lecture. Thank you very much. I don't know if Tom's got any comments on
Yeah,
this.
I think it's great. Thank you, Francesca. Excellent. I just wondered what your thoughts are. I remember when in gynae, everyone decided they had to do vaginal scans, but I'm aware that in some a lot of lower resource settings, we've talked about this there, that vaginal ultrasound probes aren't always available. And so how much anatomy, with I don't know how many people have relatively new abdominal probes, but do you think you can do a reasonable job with a transabdominal scan? I mean, where are the limitations, if you like, and why should people, if necessary, work hard to get hold of a vaginal probe if they can, and how does that change things?
Yeah. Usually I advise to, obviously with transvaginal ultrasound examination, we can assess much better the organ, in particular the bladder, ureter, and the structure surrounding the cervix.
Yeah.
For example, with the uterus and the ovaries, we can do the ultrasound examination using convex probe. It's okay, but I think to assess the morphology of the organs, it's better to use an endocavitary probe with transvaginal or transrectal examination.
Yeah. Go on, sorry.
No.
Yeah, no, I mean, I think it's about how much information you need. I think in some circumstances, almost if you're triaging, for example, you can tell if there's a intrauterine pregnancy quite often on an abdominal scan these days, and that's enough. But you might not see an ectopic. Do you know what I mean? So you'll have more pregnancies of unknown location. You'll identify someone has a pelvic mass, but you won't be able to do a good morphological assessment. So I don't know what you think, Theo, but I mean, is this a problem, do you think, availability of vaginal scans in some areas?
Well, I mean, yes, obviously it's always going to be a problem because it's an extra probe, an extra cost. But I think increasingly, and I work with ISUOG outreach, what we realize is that if you are able to demonstrate the importance of the transvaginal probe, increasingly units and the sonographers are adopting this. And once they know what the transvaginal probe can do, they really go back to doing transabdominal. And as I say, it's like doing transabdominal, then putting your spectacles on. So whenever I come across sonographers in Ghana, I do try and teach them transvaginal scanning, and I think it's always been very well received. And it's also about us understanding how to present it to the patient as being a useful tool that will give us more information about her condition. So I think with the right counseling, so to speak, of sonographers and then patients, I think it's actually something that can spread, because you've got the money for a machine and a probe. Maybe adding an extra probe isn't too much of a stretch.
No, 100%.
It's just really knowing why you should have it, and I think lectures like this explain that.
Perfect. Okay. Well, I think that's the message you've got to get across. Really, is that it's critical, really, that you have the right the job. Well, now I don't know. I have no idea how to do gynecology now without having a vaginal probe in my hand. If I'm honest, it's like I can't do it anymore.
Exactly. I can't do it either.
Okay, well, I guess Francesca, thank you so much. I mean, I always think your lectures are wonderful, and not only is the message great, but your animation, the amount of work that you must put in to make the animations that you do and everything is very well received. And thank you very much indeed.
Thank you.
Thank you so much. we have quite a tight schedule, and because of the online nature, we've got to be fairly brutal in timings, and so I hope people don't feel they're cut off too early. And it's my pleasure to introduce our